Hello, hello. This
Okay, it's working.
Thank you.
Mic check, mic check.
Hello. Hello, everyone. Good evening. Okay, so if I have your attention, we can get started, please. So it's going to be another exciting session in this conference that I would describe as very key to what we are doing. And this time around, we are going to be looking at the topic of how Nigeria TB program leveraged on lessons from the COVID-19 pandemic response to improve TB case finding. So we are fully aware of the COVID-19 pandemic and all the things that came with it. So the disruptions that we had with the health system, the service delivery across all program areas. And of course, tuberculosis was not an exception. So in Nigeria, we equally had those disruptions, and the disruptions came in various ways. We had disruptions that led to poor attendance to the clinics. We equally had issues when the vaccine was introduced. We had issues around vaccine hesitancy on the part of the people for various reasons. There was mistrust of government about the COVID-19 issues, whether it was real or not. There were also issues around low risk perception of the importance of COVID-19 and all that. So we had challenges with delivering TB services. We had challenges with people accepting the COVID-19 vaccination. And I'm sure that this was similar to most countries. But what we gained from the COVID-19 response, from the COVID-19 issue itself, is that it made various programs, including the TB program, to look inwards and think of innovative ways of delivering services. These innovations came in the form of driving community-based activities, and also we were forced to integrate with the COVID response itself, which had all the money. So I would say that the COVID-19 pandemic, as much as it was not something that was welcome, but it gave us the impetus to be able to look at other ways of doing business. And this has continued to linger on even after COVID-19 ceased from being a major problem in the country. So we have here persons who are going to be sharing experience with us on how the Nigeria TB program, utilizing support from the USID to support the TB case finding adapting from COVID-19 response. First of all, I'd like to introduce myself. I am Dr. Rupert Enogu. I work with USID Mission in Nigeria. And here I have my colleagues, Debbie Nongo, who will be presenting on the first topic. I equally have Dr. Bola Tito and Dr. Austin Ihezie. So I would like to call on the first presenter to go ahead with the first presentation. Debbie Nongo, please.
Thank you, Rupert. Good evening, everyone. Rupert already introduced me, so I'll just get into the presentation. I've got no conflicts of interest. Um, so the topic I'm actually talking about today, and we're basically, between three of us, we're going to tell you a story of how um, some of the lessons we learned from COVID have helped us in improving TB case detection. So for some of us that were involved in the COVID response from, when it started in Nigeria, we quickly learned that even though for years we've always heard that funding wasn't available to do the work that TB community needs, there was suddenly a global health pandemic with symptoms that were exactly like TB symptoms. Maybe it killed faster, but it kind of spread the same way. it affected everyone, and suddenly there was money. So, of course, the country called on people who were already working in TB to come help, address the pandemic. And through prioritizing what needed to be prioritized at the time, we quickly learned that, first of all, it was an opportunity to take advantage of the resources that were available to see how we could address things in TB. But one of the key lessons that I want to share today is what COVID taught us. And my presentation is going to follow this outline. So I'll give you some very minor background about the COVID-19 situation in Nigeria. Because we didn't test as much as we should have, we only, as at the time this presentation was being put together, we only had 266,000 cases on record, but we know that there are more COVID-19 cases than that, and only 3,000 recorded deaths. But we also know that, a lot more people died from COVID. And then with the vaccines, we did have a national target that was basically looking at people who were 18 years and above. And based on that target that was assigned to the country, we've been able to achieve up to 70%. But this was hard won. Like Rupert initially mentioned, there was a lot of mistrust in government to start with, and then a very low risk perception. So one of the things we decided to do was get public insights to help us quickly understand what was going on, understand what the misconceptions were, understand what the issues were, understand what those nuances were that if we addressed, we could get people to adopt the right behaviors, but also convince people that they needed to take the vaccine. So, so this was a program. We basically had multiple layers of telephone polling. We did them at national level, we did them at the state level. We had targeted populations, so sometimes we would do polling for just healthcare workers or a particular kind of healthcare worker. So we used this means to be able to quickly get information from the public. Those sample sizes were always weighted to give us the insights into, to give us data that we could extrapolate if we needed to. We often had a combination of static questions that we wanted to use to look at trend, and dynamic questions that we were using to basically figure out things that were happening, topical issues that were happening at the time. So for instance, if there was a particular rumor that we felt we needed to track to what extent people believed, then we would ask questions that were targeted. So these questionnaires were often updated on a weekly basis with a lot of stakeholder engagement. So every single person that we felt was useful would have an opportunity to put, add their inputs to the questions and also review the results. So this was a very collaborative process with multiple stakeholders involved. So here's an example of some of the data that we're looking at the initial part of the pandemic response. So you will see some trend information around trust and concern. These were like questions that we asked for every single iteration of the polling, just to see if the changes were happening or moving in the direction we wanted to see. And then we also had dynamic questions like those on the right-hand side, when we were at the time trying to see if people would be interested in taking the vaccine if it was released. We also had questions around food security, because at that time we were trying to understand what people's priorities were, how the pandemic was affecting people. When the vaccines came, we also looked at issues around perception. How were people perceiving the pandemic itself, and what did they think about the vaccine? So those are the kind of questions we asked. And then, we started to use this to also measure uptake once the vaccines were introduced and we were, pushing them out. So these questions were, like I said, at multiple levels. This example is looking like on a national level. So, but then we would break it down into the different geopolitical zones so that we could understand where to target resources, where to send messaging. So there are a lot of questions that basically just helped us, move the program in the direction that it needed to go. The insights were always shared, like I said. They helped us understand the drivers of hesitancy. They helped us understand who our trusted messengers were, what the right channels were to use, and then we were able to also use those insights to tweak the communication materials that we were putting out on the radio or TV. There's a lot of insights that we could get to this. I mean, we have a limited time to present, so these are just some of the key insights that we got. So first of all, we're pleasantly surprised that healthcare workers were the most trusted people, not religious leaders, not government leaders, obviously, or traditional leaders. Of course, we quickly understood that distrust in government was an issue. We were able to also figure out that the statistics and the numbers that were shared every day were not what was moving people, but hearing stories from survivors made more sense. So some of these insights helped us really to tweak our programs. Now, after things sort of quieted down, we started looking at how this kind of activity can help us on the TB side. So we haven't done a lot of it, and I'll show you later on some of the insights we've gotten, but basically this helps us. I mean, it's an opportunity for us to use this kind of activity to understand what the current knowledge, attitudes, and practices around TB are without spending a lot of money doing like those CAP surveys that, I mean, for Nigeria, I think the last CAP survey was done in 2007, thereabout. So this kind of activity would help us understand what do people know about TB. It can also help us understand the barriers that our patients are facing, or what happens when they go to the facility when they have those symptoms. It can help us understand how well our programs are doing. There's some interventions that we do and we struggle with measuring. Like we're like, how do we tell the story of, has this thing worked? We try something in a particular place or a particular population, has it worked? So if we have like a targeted telephone polling to that particular population, then you're able to answer those questions as well. So, I mean, we've looked at this and it seems like it's a really good thing to do. So we did add some TB questions to one of the surveys that we did. We were basically trying to look at things around stigma, which is always an issue, and again, what knowledge people had. And that one time that we just added a few TB questions, these were some of the insights we're able to get from it. So we were, I mean, intended to examine current knowledges about TB, assess the level of stigmatization, and explore perceived TB risk and vulnerability. And I think the information we got was useful, but the second presenter is going to tell you how these insights have transformed our programs, and the third presenter will also tell you how some of the knowledge that we gained from the telephone polls have been used to find more TB cases. So I'll stop here. These are my acknowledgements, and I think questions will wait until everyone has presented, right?
Yeah. Thank you very much, Debbie, for sharing those insights. You can see it was quite informative, and how the program was able to pivot on that information to be able to address issues around TB case finding is quite informative. So I would call on the second speaker, Dr. Bola Tito. She will be talking about how we are improving COVID-19 vaccine uptake through integrated social behavior change messaging and community outreach services in Nigeria.
Thank you very much, Dr. Rupert. Yeah, I think this is working. You can hear me well? All right, thank you. So I have no conflict of interest to report, and I'll be taking you through the effort to improve COVID-19 vaccine uptake through integrated social and behavior change messaging and community outreach services in Nigeria. And these are my presentation outline. So the slow uptake of the COVID-19 vaccine is well documented in Nigeria. Like Debbie said, there were a lot of hesitancy, a lot of distrust in the government. And the access to the vaccine is affected by multiple factors. There were also concerns around the safety of the vaccines and the low-risk perception. People don't feel that they were at risk, so there was no need to take the vaccine. Breakthrough Action Nigeria, led by John Hopkins University Center for Communication Program, we implement social and behavior change interventions for tuberculosis and other diseases, and we do active TB case finding with service delivery partners. So increasing access to medical services through community outreach and motorized campaign yielded great gains for us during the pandemic across all the thematic areas where we work. Routine immunization for children, malaria services, just taking the services to the people, we saw a change. And the use of motorized campaign, you'll see the pictures later, that was also one of the innovation that came in when COVID restriction was in place. So we found out that offering diagnostic services together with the community HSBC activity considerably increased the number of TB cases notified and the patients that are placed on treatment. So what exactly did we do? We added COVID-19 messages, the testing and the vaccination to our already existing TB messages, and we received COVID-19 funding, during that period. So initially we had our communication material and everything. After we have done a human-centered design study, we knew exactly what to say and what to do to bring people come for TB testing, because that was our main mandate at that time. How can we increase the TB case finding in Nigeria? So that was what we're working towards when the COVID-19 vaccine happened. So we had to adjust and added the COVID-19 messages to our already prepared TB messages. And then we started doing integrated community outreaches, mobilizing people for both the TB screening and then the COVID-19 vaccination and testing offered at different service delivery points. And from the picture, you can see when people actually come to a place and they're screened for TB and they're not presumptive, so it's like, oh, so I won't take anything. So you say, no, you can go for testing. And then they just go, without thinking about it. All those distrust doesn't come up at that point in time. It's like a peer influence kind of thing. Because everybody is there, everybody is taking one service or the other. So I can't go without taking anything. So they just take the vaccine. So it was really, really working. We had print materials as well that describe TB symptoms and COVID-19 symptoms. And then we use the call center number 3340 to encourage people. They have symptoms. If they take this leaflet away with them, they can call the TB hotline, and they can also call the COVID-19 hotline as well. So we educated and mobilized the community as well, key stakeholders. So these guys walking on the street, usually there's a vehicle following behind with, Nigerian music now. It's either something that will really nice, enticing people to come out. They're dancing, they're going around, They go to key community leaders as well and try to educate them about both TB and COVID-19. And that way, they encourage them that they can come for any of those services. So some of the activities that we had under the TB program, like the National Testing Week, like the Child Testing Week, the World TB Week, we usually go along with the COVID-19 vaccinators as well. And it became routine. So if they see you with Sputum Cup and there's nobody to vaccinate, they will ask you, but the other time you came with people giving vaccine, where are the vaccinators? So that way the acceptability of the COVID-19 vaccine increased. And then some other programs that saw the increased uptake, they started tagging along. So in some states, you see nutrition partners going along with the team. They can screen the children for malnutrition and administer the plumping nut and all that. We also had mass media materials. As you can see in the picture, I don't have here to play for us, but the COVID the TB materials that were already prepared, just adding face mask to those characters was a lot of game changer, so it could speak to both TB and COVID. And interestingly, patients that felt stigmatized when they asked to wear face masks in TB clinic, now it's not a big deal. Everybody is wearing face masks, so that also helped. So the materials, we had 6 television spots, 6 radio spots, and it says that not every cough is due to COVID-19. It could be tuberculosis. Check AMO, make you sure. That is, go and check it so that you're sure. because if you don't go, you will not know. Then you can call 3340 for more information. So that was the message for the tuberculosis. So using this animation as well reduces the risk of stigmatization. Before then, some of the materials on TB, they had scary, sick-looking people, which they didn't find appealing. So we use these bright colors, and then we use this animation so that there's no issue of stigmatization to appeal to people. And then the COVID team as well, they developed Follow Who Know Road. So you have this Follow Who Know Road campaign, talks about protecting yourself and your family and your community from serious diseases. And the slang there is that show love, gets vaccinated. So putting these two materials on air, it's kind of like speak to one another, and we use it during the community activities. So after 9 months of implementing integrated community outreaches and motorized campaigns, more than 400,000 people were reached with both the TB and COVID-19 messages. And then we had 81,000 people screened for TB, and 24,000 and above presumptive TB cases were referred to the health facilities for TB services. And then 77,000 people were also vaccinated for COVID-19. This is just 9 months of implementation across 7 states in Nigeria. The lessons we learned from that is that integrating communication can address people's fears and reservation about an issue and creates demand for a service and a product. So these lessons learned, we have also implemented it in a recent diphtheria outbreak in Nigeria. So in Kano State, for instance, where we had outbreak of diphtheria, so we just went with the vaccines and then the communication also. So when you're talking about TB, you educate about diphtheria, you explain the symptoms, and then it allays the fear, and then, allow the health worker or the health services to be assessed. So combining integrated communication with community outreach with immediate provision of services can address most tough issues, especially COVID-19 vaccination, with all the high distrust of government, the suspicion about the vaccines and everything, because we're talking about other things. In some states, they were doing fasting blood sugar, they were doing blood pressure check, they were doing malaria test and all that. So it allayed all the fear. The services were there and then. It's not go to the health facility. So the service delivery partner was taking the sputum sample, where the mobile chest X-ray was available. They were doing the chest X-ray there, and screening people immediately. And I said that chest X-ray was really a game changer because it really helped lots of people to come out. So integrating services, taking services to the people, it has the potential for rapid coverage, improve people's confidence in the medical services, and a perception of vaccination as a community norm, which will allay their fears and encourage uptake of the COVID-19 vaccines. So the lessons learned from integrating COVID-19 vaccination and TB is being used in integrating all adult vaccination messages, since the risk perception for COVID-19 has dropped significantly. So now you can't talk about COVID-19 vaccination in Nigeria, for instance, because it is not, the risk is not there. So what we're talking about now is integrating all the adult vaccination, so making adult vaccination seems like the norm, the in thing. So you can take for anything, whatever is the issue, including COVID-19. And that has really helped and sustained the ongoing vaccination program in Nigeria. I would like to acknowledge USAID for the support, the government of Nigeria, and amazing partners, KNCV and IHBN, because when we create the demand, they are there to meet the demand, and that improves the confidence of the people in the program. Thank you very much for your attention.
Thank you very much, Bola Tito. She has explicitly told us how we are able to integrate services and get the best outcome. So from this presentation, you would see that the integration is not only on the part of the disease program itself, but also on the part of the implementing partners. So it was not just Breakthrough Action doing this. Breakthrough Action was doing it partnering with other core TB service delivery partners, KNCV Nigeria and Institute of Human Virology. So to round up this session, we would call Dr. Austin Ihezie to share experiences on how we leverage lessons from the COVID-19 pandemic response for TB case finding in Nigeria.
Good evening, everyone. I'd actually planned to say bonsoir or bonsoiré. Okay, so we are wrapping up with this presentation. I have no conflict of interest to declare, and I'll be discussing driving community access and uptake of COVID vaccines and TB services through an innovative integrated health delivery approach. Really, the key word here is integration, and I think that's the word, the buzzword that we learned from COVID. It's so nice to, come to this conference in person after COVID happened. So there's a lot of things that we've learned, and this is part of the story that we're sharing today. So I'll take you through this with this outline. So as a way of background, like I mentioned, COVID-19 really did disrupt health systems. At some point, we had the lockdown, and beyond the lockdown, our services were restored. People found it difficult to come to health facilities and take up services because of a number of issues, okay? Of course, part of it came down to information, misinformation, distrust, and things like that. We know that in spite of what happened during COVID, Nigeria was among the very few countries that was able to record a slight increase, in TB case finding. And that was because before COVID, the country had started looking towards the community in terms of, active case finding for tuberculosis. My colleagues have already mentioned that there was a lot of issues around vaccine hesitancy, and the COVID-19 vaccination campaigns and other disease control programs, including TB programs, were forced to innovate on ways to deliver their services to communities and to the people alike. So far, as at the time we put this together, about 80 million persons had already had COVID vaccine in Nigeria. So our intervention was the USAID-funded GLOVAX project that was implemented by KNCV Nigeria, and it deployed a strategy of integrated health service delivery outreaches to communities to increase access and uptake of the COVID-19 vaccinations. So it translated lessons from the bidirectional screening of TB and COVID, which we had learned in the early phases of the epidemic. So for the COVID vaccination, in the initial phases, the vaccination was given at the health facilities. When they noticed that over time, people were not really taking up these vaccines, we now had to move the vaccination to the community. In the facility, also part of bidirectional screening for TB and COVID, because the symptoms were similar, as we encouraged the healthcare workers to screen for COVID as they were also screening for TB. But of course, with the gaps that we had with COVID vaccination uptake, we now had to depend on the COVID vaccination in the community to push TB services into the community. So the GLOVAX campaign commenced field implementation in July 2022, initially with COVID vaccination teams alone, but later on, about a month or two later, we introduced TB screeners to make the team complete. So each mobile vaccination team for COVID had both the COVID vaccinators and also had a TB screener. So our intervention really included TB screening services, blood sugar testing, blood pressure monitoring services offered to screen diabetics and those that had possible hypertension in the community. So it was also two-pronged in the sense that we had two types of teams. So for a first team, you had just the mobile vaccinators and the TB screeners without any other additional equipment. So they screened for TB using the WHO for symptom screening. But for the other team, we had them, go to the communities with the Wow Keke here, And on that particular keke, which is a modified rickshaw or tricycle as it were, you had the portable digital x-ray with artificial intelligence. You had a molecular diagnostic, either TrueNAT or TB lamp test. And you also had the COVID vaccination services all put together. In addition to that, of course, you also had the blood sugar testing as well as the blood pressure monitoring kits. So the Wow Keke basically is just an innovatively customized rickshaw meant to accommodate all of these services and provide point of care screening and diagnosis services for TB in the community in an integrated manner. Of course, it also had a public address system that had the ability to, blast music, make some noise when they're in the community, and attract people towards the service and provide that service to them. So basically, it became a patient-centered one-stop shop for these services to be provided. And of course, you can see in that picture there where you have the portable digital X-ray working. So for the results, for that GloVax project, we were able to vaccinate close to 3.5 million persons, out of which 1.4 million of them were screened for TB. That's about a 41% proportion. From this number, we had a presumptive TB yield of about 4%, and close to 1,000 TB cases were diagnosed, all because we were able to layer TB screening on top of COVID vaccination services. If we take a closer look at the results, remember I said we had two types of teams. The first team was basically the team that deployed TB screening using the WHO 4-symptom screening checklist, while the other team used the Wow Keke with the molecular diagnostics and the portable digital X-ray. And you can see there, the difference in terms of the additional value that the Wow Keke team brought to it. So a presumptive TB yield of 4% for, the mobile screeners versus a presumptive TB yield of 18% for the screeners that were using the Wow Keke. A TB yield of 2% versus 8% for those that use the Wow Keke. Of course, the additional value of the portable digital X-ray that is more sensitive as a screening tool, on-site diagnosis by the molecular test, which is also on board. That also translated to, immediate placement on treatment or shortened time to treatment for the patients that were diagnosed. And of course, you have all of the lessons that were brought in from the poll insights and from the messaging put on the Wow Keke. So you also have messaging on the Wow Keke, the branding and all of that brought and attracted persons to this particular intervention. So our lessons learned, really, it just boiled down to integration. COVID taught us to think about how to be more efficient with resources, the scarce resources that we had. That is what it brought out. And of course, the fact that we're able to provide a bouquet of services meant that persons can come, are attracted to, that service delivery point for different services. So even if they did not need TB screening, they came for the COVID vaccination. They came for the blood pressure check. They came for the diabetic screening. So one thing or the other brought them towards this, and they were able to, have their health needs addressed. Designing health interventions and communication messaging using insights from the polls and from end users, the end user results gave us better outcomes in terms of interventions. And by leveraging on various health interventions through an integrated health service delivery approach, we can mitigate some of the issues around funding gaps in TB programming. We can increase TB screening and, of course, ultimately improve TB notification and treatment. I would like to acknowledge all of our partners that helped make this a success. Thank you very much.
Yeah, thank you very much, Austin. I think listening to the three presentations, we realized that the COVID-19 pandemic was not bad after all. I mean, there were positive sides to it. One of the key lessons that Nigeria learned from the COVID-19 pandemic is the importance of integration. We have been able to integrate at various levels, and this has significantly helped the way we are doing business. That Nigeria was able to increase the case notification in the year 2000 and have been able to sustain it thereafter is essentially down to what we have seen presented here. So I would like us to take some time, about 10 minutes, to ask the presenters questions, clarifications, and make our opinions known. I don't know if anyone has any question for our presenters. Yes, please.
Thank you, presenters, for sharing. I think for me, the first thing is to say, like the moderator said, something positive out of COVID. But my major concern is how did we manage to get the healthcare, the frontline workers, to still come out in the midst of the fears and anxieties that were, part of the COVID pandemic. What was the selling point to bring out that level of courage and conviction for those frontline workers to still go out there and do what they had to do? Thank you. Anybody can take, please, because it's just similar.
So I'll start. I think I might have touched on it briefly, but one of the insights we got from polling was that, first of all, the healthcare workers were the most trusted source of information. And that result came out consistently. At the same time, we also got to know that the healthcare workers also had their own level of hesitancy about the vaccines. So at the beginning of the pandemic, they were concerned because they didn't have the knowledge they needed. A lot of them told us that their source of information was Facebook. That's where they were going to get knowledge about COVID-19. So getting those insights meant that NCDC knew where to target training, or MPHCDA knew where to strengthen information. So educating the healthcare workers gave them confidence to come out and do the work. And also knowing that because they were able to prescribe vaccines or convince people to take vaccines, that they were protecting themselves and their families, I think that was encouragement enough.
All right, thank you. Does anyone else want to add to that?
I think also going out with the team means additional stipend for their families. And COVID was a hard time for everyone. So the fact that they have opportunity to get extra source of income, was also a motivating factor to go out.
Thank you. Can we have another question, please?
So, for me, I heard here that COVID taught us lots of lessons, and then it's really good to see how the integration led to high yield of results. My question would be with regards to the vaccination of COVID-19, like you mentioned, Dr. Tito. I would like to know, because from here we are hearing a lot of conversations around TB vaccines. There's going to be big announcements happening early next year and all that. It would be good to know if Nigeria already, through the lessons that you learned, COVID taught us a lesson, it hit us, we were not prepared, but Nigeria managed to do all of this. Is USAID, Breakthrough Action, and all of you back at home, are you already thinking of strategies that you want to put in place before this big announcement is made, so that the environment is already prepared for uptake by community members? I'm just keen to know.
Who takes that? Dr. Tito and Debbie.
So I think the buzzword today is integration.
Yeah.
We've realized that we have to integrate our SBC approach as well, whether it's focusing on prevention or convincing people to increase service uptake. The bottom line is one patient can have diabetes, TB, COVID, name it. It could be a pregnant woman who's suffering all of this. So one of the lessons we learned from COVID is actually integration, including health messaging. And, other SBC programs, for instance, look at the life course approach. When a woman is pregnant, she will need this. When she has the child, she needs immunization. As the child grows, she needs messaging around malaria and all of that. But we're also realizing that the infectious diseases can also come, pandemics can happen, and will affect everybody. So as a donor agency, we're, like I said, the buzzword is integration, including SBC approaches. We're looking at how do our programs address the issue of prevention in general? And it's not just TB prevention or malaria, like it's prevention. So that messaging should, talk about prevention in general to the household, to the youth, to whoever the subpopulation is. So I think I'll let you talk about the actual details.
So I agree with the integration component, and I'm glad that USAID is here with us. The preparedness for the vaccine is very important. Let me give you an instance. When the HPV vaccine was launched in Nigeria, with the NPSCDA, we gave them clear outline on what to do, and who to engage before the actual vaccination started. But they missed some people, and they were more like reacting to, issues of resistance and, rumors and all those negative things. So if we're well prepared, apart from the integration, we have some stakeholders we really need to engage before the vaccines get to the country or before we start the distribution, and explain why we're doing what we're doing. And then the integration will start, the integration, and then appropriate communication, targeting some people that you just know them. They are there for, to confuse people, or they think they know when they don't know. So those people with this information, yes, we need to, address them and make sure that they are on board before we start.
Okay, so just add to this, yes, because of time, I want to say that healthcare workers play a very key role, okay, in the success of any vaccine rollout. Very, very key role. And with the moment you miss that step and you don't engage them enough, provide them enough information, I think that's what actually changed with the COVID, giving them that courage to be able to go out. Because initially they were afraid and they were concerned for their lives. But when they had enough information in terms of knowledge and they understood how to protect themselves and all of that, they had, of course, we have the incentive coming in, but that helped them to make that decision to be able to step out and help others. Thank you.
Okay, we just have about 3 minutes to round up. We take the last question from Dr. Gidado.
Thank you very much, Rupert, and thanks to this team. I'm really very proud of this work because I think we have struggled with integration, especially into routine vaccines, for a very long time. I'm one person who tried this with the polio vaccine in 4 states and it didn't work. So I think these lessons now, I would like to make a plea that we should discuss at a national level, how do we leverage all the vaccine opportunities. There is a routine vaccine for adults, there is a routine vaccine for children. Home visits are done on quarterly basis for polio vaccine. TB diagnosis among children is the biggest of Nigerian problem at the moment, and this now becomes a platform as an opportunity. So I think these lessons we have learned from COVID, I would like to really encourage this group, take it as a mandate. Help us fight until we are able to integrate some of these lessons into the polio vaccine and into other routine vaccines program in Nigeria, because it is a missed opportunity where we can get some patients. But thank you very much for these lessons.
Yeah, thank you very much. And so that's a comment, and I don't think there's a response needed. But let's take one last question from Dr. Moni.
Yeah, thank you, Nigeria team. I think I will come and visit you from my country when the time comes. Yeah, but I just want to say that I know this is going to be published. Please publish it. In the next 2-3 years or 4 years, there will be TB vaccine. So there are key important things you have learned, lessons you have learned that will help in rolling out of the TB vaccine. Please, when you are publishing, remember to put those things that when we are running out TB vaccines, these are some of the things we can learn. These are some of the things we can do. And then when you are publishing, put my name.
All right, thank you very much. Thank you very much. Please, can we appreciate our panelists? Yeah. So just like a last word from me, and I mean everybody has said it's all about integration. Nobody should be designing a program without thinking integration at every stage of it. Thank you very much and do have a nice evening.